Welcome everyone to episode 30 of our Future Proof PT. And today we have a unique privilege to have Dr. Trevor Lentz on our podcast. So thank you for dedicating your time to us.
Yeah, it's great to be here. Thanks so much for the invitation.
So I'll preface to say that I have been reading your work for so long, and I feel like it has been a foundational pillar to a lot of what I try to present to at least the community that I talk to, because I think there is a lot of truth, but also I think a lot of nuance in your academic work. So, what is your background? Tell us a little bit about you and what got you into this space.
Yeah. It's been 20 years now, I guess, since I graduated from PT school, which it doesn't seem like that long. But I spent a number of years in practice, primarily in the sports and ortho area, treating a lot of post-surgical sports-related injuries. And I think one of the things that really struck me in managing that population was just how much it ultimately became not so much about the impairments, but about the experience of recovery. And I think as a younger PT, I felt like I just wasn't really well prepared to address some of those things. There are things that now we think about, like mental health, psychological distress, stuff like that. And I thought, wow, so many of the patients that I think about, when I leave the clinic, and it's like, how do I get these people better? I just didn't know how to address a lot of that. And that led me to do some clinical research while I was still in practice with some colleagues that I had at the University of Florida. And I mean, I got hooked. I got hooked on trying to answer some of the questions, trying to, fill some of the gaps, I think, in clinical practice that I had and that I think other people had as well. And very fortunate enough to be able to leave the clinic and get into to academia research as a sort of my second profession, and then just been really opportunity to be mentored by a number of people that have helped me understand how to answer some of these really important questions. And it's kind of been a circuitous path over time. I've gotten into a lot more health services research, understanding like what is it about the way that care is delivered that is somewhat misaligned with the needs of the people that are coming in to physical therapy to see us, and how do we deliver better value for them. And so using some of the big data type studies that I've had access to and been able to do, but also some qualitative work, some work in measurement and design of instruments to evaluate psychological distress. So really trying to get at it from a variety of different areas. It's been a fun path.
What is your day-to-day like in the role that you have now, Trevor?
It's mostly research focused. I do some teaching in the Duke DPT program, evidence-based practice in pain management, but it's mostly research, which is great. So we've got some trials that I run, which I'm PI for, which is almost like running a small business where you've got your employees and the things that you have to deal with, fires you have to put out. There's some work that I'm doing within the Duke Health System where we're trying to take data that we collect within the health system and turn it back around in a learning health unit to understand how we can answer questions very quickly, which is kind of a cool thing that I've been doing over the last year and a half or so. But that's my writing right now. Is I'm in a grant writing cycle, trying to get a few things out, but a lot of writing, presenting. It's usually no 2 days are the same, which is great.
Yeah, that's pretty awesome. So it's like, there are two types of learning: the inductive and deductive learning, right?
Mm-hmm. Yeah.
I have a feeling, and I've been a PT for almost now 24 years, but there's almost a feel of that the cohort of clinicians are used to being inductive, and it's a challenge to get people to the deductive position of being question seekers, not answer seekers, but actually asking the right question. What do you think is a way for us to shift our clinical community to be able to ask the right question and be comfortable with uncertainty that not all the answers are going to be available?
Yeah, it's a tough thing because I do see that in some of the teaching role that I have, where it is creating critical thinkers, but also helping to impart that so much of what we do, there's so much uncertainty about it. It's very rare that something is completely black and white. There's so much uncertainty, and how we treat, how we evaluate, what somebody's trajectory is going to look like. I don't know if I have a good, answer for how we do that other than making clinicians and students and new graduates aware that, this is going to be a lifelong, a profession long, as long as you're in the clinic, you're going to need both deductive and inductive reasoning, that not all of those answers are going to be there for you. And sometimes you have to take information that's around you and understand, how do I apply this to the patient that I'm seeing? So I don't know if that's an issue of just setting that stage or setting that expectation in our graduate programs, or if there's some other magic thing that we need to do to make, I think, people think more in that way. I agree with you, Alex. I think that needs to happen.
I know we were going to ask you about your study with removing financial barriers to therapy through the no copay revolution. I'm definitely interested in the behavior component, in all my work in value-based care. It's really about what incentives change behavior. And changing the incentives financially, it changes changes behavior and changes outcomes. And it's like getting them right is hard. It takes research and practice. And so I'd love if you could just tell us about what you found, how it worked, and then we could chat about it.
Yeah, no, that was an interesting project. Some colleagues that I've been working with for a long time at ATI came to us and said, we've got this program that, we've worked with the self-insured employer group that has implemented this we together have put together this program of no copay model for, musculoskeletal conditions in PT. And we want to take a look at it. We're at a position now where we've got some data and we want to evaluate sort of what happens when we integrate something like that. And what was kind of nice about it, and I don't think this was in the paper, so this is a little behind the scenes.
Oh,
but we did have some pre-implementation data, so few years prior to, and then afterward. And so what you saw in the paper was that with this program that's implemented, where there's removed copays essentially, and made sure that the employers understand that this model is available to them, we see a shift of the people that use it. We see a shift toward things like physical therapy, I guess what you would consider to be more guideline concordant treatments, and away from things like imaging, not surprisingly, physician visits, and also surgery. Some of the things that we couldn't report on, or we didn't report on, was some of the costs. So the cost savings is an interesting thing, because what we see in this project and others is that sometimes the cost savings isn't huge, isn't massive, because and essentially what's happening is that, as a lot of the costs that we're saving from fewer surgeries and imaging is taken up for, at least to some extent, by a lot more physical therapy use. But what we did see with that sort of pre-post is that we did see some modest cost savings, before that program was in place compared to afterward. The really important thing about that I think is important for payers to understand is that, we're not seeing these massive increases in costs just because we're reducing the copay, we're removing the copays, which I think is really important. So when I think about it as like a non-inferiority type study, it's equivalent at best, and maybe even a little bit of cost savings for a program like this. But it was not too surprising that we found what we did, because there are other studies that are out there that have shown that, the Optum study, Dave Elton studies that have looked at reducing or removing copays have shown something similar. What was really nice about it was that this is yet another example of being able to finding something similar by removing or eliminating copays. The biggest issue is just the selection bias. And that's the thing that I think most people come back and say, well, these people were probably going to use PT anyway. They were probably going to get better anyway. And, to do a study where you really drill down to, who are the people, or how many people have used this now that the copay is gone versus would have used, not used it before, it's really difficult to determine. How do we better characterize the true value or the true benefit? How many people are we actually changing the course of their care because they've received this versus having a copay that they have to pay?
That's really interesting. I think if you look into that horizontal and vertical value, we focus on more of a horizontal value of these barriers to access, which are financial barriers to access, and how they impact the utilization. Now, we fail to recognize vertical, and these verticals, I think, are constrained by even our ability to capture all this data. So you look into the overall cost of care, and then you look into the social cost of care, and you look into the global cost of care. It's just like turtles on top of turtles, right? So getting to the bottom of the actual cost versus saving is so hard to predict. But in an ideal world, if you had to take away any environmental constraints from academia and any constraints from research, what would be the optimal time frame to study the actual economic utilization? If that's possible, do you think then do we just need more of these horizontal and vertical studies that capture both the global data from healthcare utilization?
Yeah, I mean, your last question is yes. We do need more of that. Um, I think one of the challenges, and I don't talk a ton to payers, but in my experience in talking with payers, their conversations with them, is that a lot of the challenge with uptake of these types of models, or at least the maybe lack of traction. I don't know what the term would be, but for a lot of these covered lives, these participants, these patients in the programs, they're maybe on the hook for a relatively short period of time, while they're employed or while they're covered under that plan. I think showing these really, really long-term cost savings, I don't know if that's more beneficial or less beneficial. I think, showing that there are fewer costs over the course of a year may be beneficial for some of those payers. My theory is that we would see even better outcomes if we were to expand the horizon and go out even longer. But I think that would only be true when the physical therapy that they are being provided is high quality. Because in theory, what would happen is that patient would see that, oh, this is a great way of managing musculoskeletal my musculoskeletal condition. When inevitably this happens years down the line, this is somebody that I'm going to continue to go to. Not this person, but I'm going to go to PT. I'm going to seek out PT because now you've sort of changed my perspective that I can go to a physical therapist and they can manage this effectively. But if that doesn't
That's right.
happen in that initial opportunity, and we see this all the time, I talk to my family members who say, oh, I tried PT and it was awful. It sucked.
Hmm.
So it's like, well, why would I, now that I've got, and that was for back pain. Now that I've got knee pain, why would I go to a physical therapist? Because they sucked dealing with my back pain. I'm going to go see a surgeon or I'm going to go see a primary care provider and they're going to inject my knee because my experience with PT was so bad. So I think it's not only just reducing the copay or eliminating the copay, that barrier, but I think it needs to be coupled with really, really high quality guideline concordant care that will reinforce the benefit of early direct access physical therapy so that over time, the users, the consumers will start to see this as being the way to do it.
I'm
Yeah.
going to add in there that the guideline concordant therapy is easier to incentivize if we look at this not just from a removing the copay as the one carrot, but adding another carrot where therapists hold accountability for those additional periods of time, whether it be 6 months, 9 months, whatever, a year. And that again leads to an accountability where they get something in return financially as a result of those longer term better outcomes, because that's really what payers and CMS really care about. But if you tell therapists your goal is now different, you're going to optimize the amount of visits and, have this patient have a good outcome and do guideline concurrent therapy, but you have the opportunity to earn an extra 30%, for example, based upon the avoidance of unnecessary and avoidable additional interventions. I think some of this is so baked in culturally that until you remove the norm to do volume and you start thinking about what's really going to lead to the best long-term outcomes, you both incentivize guideline concordant evidence-based care and you incentivize the therapist to kind of own that patient as that patient's therapist over the course of not just of whatever that episode is, but to your point, like a primary care doc does, they come to you in the future. They call you, they have a way to reach you. So kind of all those things going together, I think that would be a great next study, is to just look at what happens when you incentivize the therapist differently and there's something in it for them by optimizing for the long term.
Yeah, that's absolutely right. I mean, I think we've got to get out of the mindset of the episodic care model and more into the longitudinal care. We do have actually a program at Duke that's called the Joint Health Program,
Mm.
and it functions within a fee for service environment, so it's not quite what you're talking about, but the design is as a more longitudinal care model. So the patients come in and they actually from sort of day one, they set up a very long-term care plan for them and they have these,
Wonderful.
regular follow-ups. So it's not incentivized from a financial standpoint, but it does start to get the therapist, I think, to start realizing, think about even the patients as well, that this is not just something that's going to happen over the course of the next 6 weeks and then I'm never going to see you again, or I'm done, or I'm off the hook, or, this is something that we are thinking about over the course of a year or 2 years. And how do we make plans to ensure that you're going to continue to improve over that time? And, we send out a questionnaire and follow-ups to ensure that people are continuing to improve over time. And if they're not, we follow up with them. But I think you're right. I mean, that's the type of model right now. It's just not financially incentivized. We hope to get there at some point. But I do think that it starts with a change in mindset.
Therapists have to speak up about when something like this is established, that they should also benefit from changing the way they approach care and transforming, their day to day. I do think we as a profession, just as a whole, we have to believe deep down that we're creating and can create much more value both than we are today and more than other parts of the healthcare continuum are used to giving us credit for. But if you say, I'm going to do this, it's going to benefit the patient, benefit the payer, I want something for it. If you set up something that's working without even the financial incentive in place, imagine, could it be even better if there was an additional reward, just like they're doing with other providers? And that's just good for the profession itself to help elevate it to the place where it really could be, which should be just on par with our physician and other doctorally prepared colleagues.
Yeah. And I think the goal, the reason, a little background on that program, it's been around for, as long as I've been at Duke, which is about 9 years. So the whole goal of that program was we needed to set something up to they weren't waiting for the payment model. They said, let's set something up and then let's show the value so that ideally, in theory, the payment should come to us. And I think they're still working on that.
Yep.
But the whole idea was let's get this model in place and get it going. And then it'll be a lot easier to make the argument that we should be paid to do this.
I love it.
So I think that's actually really interesting. To go a little bit back to what you were saying about your relatives who, with a path dependence and having a negative experience on one specific type of treatment, and then not following up with clinical care and the other treatment, what do you think we have to do, and why do you think we've been ingrained to associate physical therapy with that single episode of care, where you just don't see that in any other clinical discipline? You don't go from a bad dental experience to saying, I don't go to dentistry anymore. What is that point of our professional ecology that we need to fix, or at least change consumer behavior from associating single bad experience with the entire discipline not being functional?
Yeah, that's a good question. I mean, I think, part of the reason, and maybe the reason that the dental one doesn't quite work, is that there's only one type of provider that can work on your teeth. So it's like with a musculoskeletal thing, you have PT, you have chiro, you have acupuncture, you've got CBT stuff, you got, primary care surgeons. I mean, there's a whole bunch of different potential options. And, maybe that's part of the issue, is that consumers in a good way have a lot of different options, because I think that the same is true. It's not specific to PT. I think the same is true for acupuncture. If I go to an acupuncturist and it doesn't work, then I'm probably not going to go back to it for something else. So it's difficult to say. I think some of it is that we probably need to rein in some of the unwarranted practice variation, definitely, because in talking with my family members that have undergone this, it's like, well, tell me a little bit about what happened. And I mean, you can guess where this is going. It's like they get stuff that is, I can't even understand why they're doing it. And it's like, well, of course that's not going to be beneficial for them. I wouldn't go back either. And I would feel the exact same way. So I think part of it is that, we need to rein a lot of that stuff in. And I don't know if that happens through just reducing payment for stuff that is not guideline supported, or if that's, the three of us speaking out and saying, hey, quit doing this stupid stuff that's not, going to benefit anybody. I think there's also the challenge, though, that as you all know, a lot of the interventions that we provide, whether it's exercise, manual therapy, I mean, they're relatively small effect sizes. I mean, we're not talking about massive effects. If they had massive effects, there'd be no need for this podcast, because it's like everybody would be getting better. But a lot of the effects that we see are relatively small. So I feel like what we probably need to do is understand how do we reinforce those effects by maybe trying to ramp up some of the contextual effects or the non-specific effects. So providing hope for patients, providing education, doing things that, providing comfort, listening. I mean, these are things that I think are pretty, I don't know that they're unique, but there's something that physical therapists are really well positioned to do that I don't think we do enough of. And just in the example that I was saying about a family member is that, part of what I heard was that, they didn't listen to me. They just stuck me on a table and, put an ice pack on my leg. And it's like, well, there are 10 different things that we could have done better as a profession in that situation that we're probably not doing. So I think, some of it is maybe working on it from a reimbursement standpoint. Just hearing from the leaders in the profession that this is a major threat to value. And yeah, I don't know, maybe you'll have some better ideas. It's
I
not
think
an easy fix.
it's a perfect segue into the next topic, right? Which is the precision therapy and treatment and coordinates. Part of, I think, that identity is lack of standardization leads to a lot of ambiguity in both the expectation as well as delivery process. And so if you don't know what to expect and you don't know what to deliver, and it's essentially a lack of draw, which clinic you wind up in, what type of care you're going to receive, and that clinical guideline adherence and best practices adherence is so vague and so poorly practiced and poorly communicated that what was the evidence that 45% of clinicians don't even know that clinical practice guidelines exist, let alone use them. To make the statement into a question, part of our identity crisis, I think it has to do with basic language and how we call ourselves. And so I just had this conversation with Drew Contreras like literally an hour ago, which is when you call somebody a physical therapy assistant, assistance means a subservient profession. So someone, I don't want to be delegated care, and this was more on a like cost savings, but the treatment delegation and stepped approach. You don't want to go from physical therapist to a physical therapy assistant. And then from a physical therapy assistant, you don't want to go to a physical therapy technician, because the language communicates that like it's a lesser service, it's a lesser profession. So maybe even the fact that we call our profession by the same way as we call our trade is a problem. So do you think we can do better precision care if we just stop labeling physical therapists? Maybe have an identity change or call it something else. Not to say that that's a negative connotation, but now that's a connotation that's associated with specific interventions. And then even with the interventions, when we call exercise an exercise, I think there's already a social stigma that exercise is something that's lower value. Well, I can exercise watching a YouTube video, right? So what do you
Yeah.
think? Yeah. So
No, so I mean, I think I've thought this for a long time, and I think I may have given a few talks that kind of mentioned that a lot of the things that I think are the active ingredients in physical therapy are not physical at all. And so I do agree with you. It's probably a bit of an outdated or antiquated type of term to use for what we do. I mean, and I don't know a better term. I don't have the answer for that, so I think what we do is our aim is to get people better and use the tools that we have available to us, whether that's exercise, manual therapy, modalities as needed, cognitive behavioral strategies, or just even reassurance and providing hope. Those are the things that we use to help get people better, but they don't all have to be physical. And so I would agree with you. And certainly to your point, I guess I'd never really thought too much about that, but you're right. I think the terms that we use, whether it's assistant or tech, that is problematic. I would agree. I mean, I think it speaks to a broader issue within healthcare. It's not specific to physical therapy, is that the words that we use are really powerful, whether we're talking about a diagnosis, and we use blown disc. I mean, that's unhelpful, or an assistant to me is unhelpful. It's probably not going to reinforce a lot of hope and confidence in that patient that person is going to be able to help you as well as maybe I would as a physical therapist. So I would agree with you. I think very broadly, we need to reconsider the terms that we use and the way that we present not only ourselves, but what we do to our patients. Because even with the, exercise, I mean, if I tell somebody, hey, I prescribe exercise, I don't like exercise. I mean, it just sounds awful. I don't want to go exercise, but if we kind of, I think, sell it or present it as a way of, recovering the things that you really like to do in your life, then maybe that's what we need to focus on, not so much on the interventions that we provide, but on the outcomes that we provide. I think that's really what we're trying to sell. But that's,
Yes.
I mean, that's kind of the way that it is in all of healthcare, right? I mean, I don't know that that's an issue that's specific to PT, but I do think that we probably need to focus a little more on what we're providing, not what we're delivering, but what our outcome is.
But so to that point, because I think I agree with you partially, we should be speaking in terms of outcomes. I think what we've done, though, is we've burdened people. We've burdened the population by thinking if I start therapy, it's going to be like 6 to 8 hours of my week between getting there and having therapy and getting home. It doesn't necessarily translate, especially in an attention economy. People want what's convenient and what's going to solve the problem and get them the outcome. But we fluff and add and burden. And then some of us are, not very interested in adapting to new technology that does sometimes take away some of that hands-on. But there's some people that do need post-surgical. They do need 3 times a week of therapy. But lots of people don't need the frequency and intensity and volume we give them. We've socialized therapists in a fee-for-service world with very limited billing codes to crank out volume. And that is particularly distasteful now to the public who want things solved and they want direct communication and they want to be activated. They don't want to be passive recipients, and they certainly don't want to do things that they feel burdensome. How do we change the mindset of therapists that, to your point, what outcomes look like? What does more standardization look like? And on top of standardization, still personalization. Like I can call you, let's set this plan up. We're going to have a quick 15-minute video call in a week. And maybe a couple days after that, you're going to come in and we're going to progress you. If something changes, we're going to message and we're going to get on top of that. But like having it's almost to more respect for our patients in a way. I don't mean it that we're being disrespectful, but reimagining what we expect the public wants us to deliver, maybe. What do you think about that?
Yeah, no, that definitely resonates. I mean, I've kind of always felt that we need a much more personalized approach. I mean, that was kind of going back to what we talked about at the very beginning.
Yeah.
That's sort of what led me to where I am now is I sort of that whole, 2 or 3 times a week, blah, blah, blah. It's just like, that is not what everyone needs. And we need to be much more responsive to patient preference and patient, their goals. And I feel like where we deliver the greatest value is understanding what that patient needs and then matching our delivery approach to that. And maybe even going a little further, saying, what is the outcome? How can we get that person to that outcome in the most efficient way that meets that patient's needs, not that meets our needs to get, however many units a day, but, what meets that patient's needs. And I've sort of always felt, because I think one of the challenges, some of the telehealth stuff and the RTM stuff, it's like, that would probably work really, really well for some people that really like that and really want that and really need that, and where it would be very beneficial to them, but that's not going to be beneficial to everyone. And, some people may actually like the very passive approach. They want to come in and they want me to tell them exactly what's going on. And they want me to tell you, what do you do now? What do you do later? And so it's a little more prescriptive. And then there are others that may say, hey, I'm doing okay. I've got, or they have relatively low risk for persistent disability. I'm going to evaluate them. I'm going to educate them. I'm going to send them away for 2 weeks, and we check in via text or via phone. And I know we're trying to get away from physical therapy. That's physical therapy. It's not just the number of times a week that you're coming in. I published a paper a few years back, and I think it was JSPT, where we kind of outlined a couple of different ways that we manage people based on their risk, like psychological distress profile. And so what I kind of liked about that was that you sort of have this tiered approach where it's all the way from one visit, evaluation, education, provide reassurance, call me as you need, all the way to I'm going to co-manage you with a behavioral health specialist and weight loss and nutrition and a primary care provider, whatever.
Yeah.
And there's everything in between, and all of that is physical therapy, or whatever we want to call it. So I think that that's really important. What we don't know right now is What we don't have right now is a really good way of figuring out who needs what. So I think we kind of probably give everyone what's right in the middle, and it doesn't always meet everyone's needs.
And I think that that's perfect, actually, to go into the part about phenotyping, right? So that there's a taxonomy and phylogeny of patient classification, and you can classify risk, you can classify selection, you can classify access and exposure, and including classifying availability of resources. If you are in a country or a community where you're resource poor, then you can get transitioned to a digital or a RTM system that is the best available option. Maybe not an optimal option for your phenotype, but optimal option based on availability. But the question here is, who becomes the gatekeeper for this classification system? Who becomes the gatekeeper for phenotyping? You did a wonderful job with your phenotyping literature and then what you've studied with like your examination. I think the question is spot on, where you have this taxonomy and the tree that branches, and each branch represents its own specific unique trait and characteristic. But you did it from a standpoint of academia. Who in a real world scenario gets the job of classification? Is it the physician? Is it the payer? Is it the employer who gives you that selection? And then based on these rules that we select, you go here, here, or here. So what do you think is the best answer here?
Yeah. I mean, I guess maybe to your point a little bit is that there are a variety of different ways to phenotype and a variety of different things. So a little bit of background on kind of what we did was that program that I talked about earlier, the joint health program. They, being that it is sort of a comprehensive longitudinal program for osteoarthritis, one of the things, not surprisingly, that a lot of patients come in was with psychological distress, anxiety about their knee and their hip. And so what they were seeing was a lot of distress characteristics that they didn't really know how to best manage, or at least not manage efficiently. And so they came to me, and I've been working with the program for a long time, but they said, is there a way that we can kind of use some of the data? Is there like a data informed strategy that we could use to help us understand how to better more consistently deliver care and get sort of like all of our various physical therapists that are part of this program? I think they have 20 something PTs that are in this program to sort of deliver something that's relatively consistent, not for each patient, but if you go in to see one PT in the program and another PT, you're probably going to get a similar, strategy. And so what we did was we looked at, what are some of the distress characteristics? How do these characteristics, these various characteristics that we know to be distinct, how do they cluster? Like profiles, like what are common psychological profiles that we tend to see for people coming into this program with osteoarthritis? And then what we did with it, or what they did, I can't claim that, they put together a program that really addressed a lot of the different characteristics for each one of those different profiles. So I kind of already alluded to this. If it's relatively low risk, in other words, low distress, their prognosis is really good based on their distress, at least. It may be something where we don't address it in clinic as much. We do some real basic education, and they're on a program that is primarily impairment based. For the patients that are really highly distressed, they have a lot of anxiety about their knee. They're depressed because of it. They have poor pain coping strategies, maybe low self-efficacy. There's a completely different pathway where they're maybe working with one of our pain psychologists to help supplement some of the impairment-based care that's being provided by the physical therapist. So in this model, getting back to your question, Alex, in this model, the gatekeeper for this would be the physical therapist, because they are coming into this program. In this model, it's kind of interesting because the PTs are sort of like the quarterback, the gatekeeper. They are not so much a primary care, because they don't all come in direct access. A lot of them are referred in from our surgical colleagues. Some of them do come in direct access, but the physical therapist is the quarterback. They are the ones that say, you have this, this, and this. Let's discuss what the plan is, and we're going to get, behavioral health involved. We're going to get weight loss. We're going to get nutrition, whatever they need. So the gatekeeper is PT. But I think, when we start talking more broadly about phenotyping, you can phenotype on a lot of things that may be unrelated to something that a physical therapist can manage. Let's say, for instance, you have, an inflammatory condition that, we identify through phenotyping that may not be something that is appropriate for PT to manage quite as much as it would be like a medical management of it. So I could see this potentially happening in primary care, where if they identify patients, let's just use the example of osteoarthritis, where it appears that they're probably best off with a truly impairment-based approach, maybe they go to PT. If it's more of an inflammatory condition or inflammatory processes or pain management than maybe there's, they're managed medically. So I think it really kind of depends on what you're phenotyping on. We were phenotyping on something that was very much manageable by physical therapists in this program. So it made sense to have the PTs do that. The other thing is getting surgeons, in our case, to do something like that is nearly impossible. And our PTs were willing to do that. And so there was also that practical, consideration of that as well. And they also, the other thing too, is that they had the time to discuss what that phenotyping result meant. We going back to this conversation about language and communication, if you don't communicate that well enough with patients and you say you're a high distress phenotype, that's a problem. That, and by the way, we don't do that. We spend a lot of time thinking through, like, how do you communicate that, or even do you communicate it with patients? Because it's really more on the back end for the physical therapist to understand what you need to manage. Now, unfortunately or fortunately, depending on your perspective, all of this stuff is in the medical record. It's available to the patient. So we had to find a way to make it so that we could put it into the record without, introducing stigma. And so we did that just through various language that we use, talking about, what potential interventions might be most appropriate for them. I can't remember where this conversation started, but it was, just going back to the gatekeeping part of it. So I think the benefit was that, the PTs have some of that time to talk through what they found with them. Whereas I don't know if that would be as much of the case in primary care or in surgery, in large part because they've got so much other stuff they need to manage. And maybe they don't have the training to do that. Whereas in our program, all of our PTs are trained in psychologically informed practice.
There's a very quick analogy here, which is there was an interesting study to see why most consumers in the United States don't follow food guidelines, even though it's clearly communicated on every package, right? This is how many calories, this is how much fat, this is because of the complexity, the language that is used in the food guidelines is difficult to understand. We don't know what calories actually mean. We don't really know what polysaturated fats are. We don't know what those So Europe actually has a brilliant system of communication, which they have two color codes. One is numbers, one is letters, and each one is associated with a color. And the one side tells you how natural it is. And so it's a tiered system, 5 different organic, very natural, semi-natural, processed, super processed. And the other one tells you how healthy it is, which is really healthy, moderately healthy, unhealthy. So it's two letters and numbers with colors, easy to understand. So if this is healthy and natural, maybe that's what I want. Or maybe today is my Friday and I'm going to have something that's unhealthy and unnatural because it's Friday and damn it, we deserve a nice glass of whiskey. But I think that's someone who's taken behavioral psychology and actually applying it to consumers. And we're still jamming the same thread. So that's just my thing. Maybe we just need that simple communication. You're yellow on the behavioral catastrophization side, and you're red comorbidity. You have multiple comorbidities. You're just you're decrepit. And I'm sorry, but that's you're yellow and red. You need this type of care. Versus you're green and green. You're healthy and you are behaviorally equipped to receive care. So I don't know. That's my spiel.
Yeah, I think we don't have that as a patient facing thing. We do have that as a clinician facing thing. So they very clearly can see. I actually think we do use colors to show what the phenotype is or where their distress is located on these different constructs. So that sort of gets to it, but yeah, it's not patient facing. We just haven't put. I think one of our questions is how much of that can you impart very quickly and easily to patients because it's so complex and because there's so much involved and because everybody's experience is a little bit different. What we'd actually do use. So I guess maybe to talk a little more about how it's used, it's not so much that, oh my gosh, you're a high distress profile, we're going to get you immediately to another healthcare provider. It actually is designed to open up communication about what's going on with it. That's the first step.
You're nudging
it's not
the
referral.
therapist.
It's not immediate.
No.
It is. It's nudging the therapist to say, it's almost like you get really no nudge if they're low distress. Yeah. You get a big nudge if they're high distress. And if they're in between, then maybe it's a little nudge just to kind of talk through some of the things that are specific to low self-efficacy or poor pain coping skills, So I guess, and I hadn't really thought about it as a nudge in that way, but But that is what we have just on the back end of it for the
But it's labeling, right? Like, so it just goes deeper into that, like, and labeling works both ways too. It's not just the therapist or just not the patient. It's both that they're receptive to labels. So let's go into that systems thinking and the Pain Navigator program, which is an example of reduction in uncertainty at scale. So can you tell us a little bit about that BA Pain Navigator program?
Yeah, this is a program that was part of a clinical trial, a big pragmatic clinical trial that was just actually published last weekend in JAMA Network Open to plug for if anyone's interested in that. It was called the AIMBAC trial in the VA. But one of the two arms was what's called a pain navigator. And essentially we're getting outside of the PT realm a little bit, but I think there's a lot to learn for PTs, is that we had patients that were veterans that were had low back pain that were going to see the primary care provider. Primary care provider would refer them to this Navigator program. What we're trying to do was get them very quickly into non-pharmacologic care for their low back pain. We didn't so much care what kind it was, but we wanted to keep them away from the opioids. We wanted to keep them away from surgery. We wanted to keep them away from interventions as best we can. And we know that very often access to non-pharmacologic treatments is poor for a variety of reasons. People about it, they don't know what's available. And in the VA, it sometimes can be tough. A veteran had a call with a pain navigator. Pain navigator was somebody that was local to their VA system. I think we had 17 sites around the country.
Wow.
And so it was somebody local that we trained in pain navigation. And essentially what they did was they talked to them very briefly about pain, but it was really more about these are the different types of guideline concordant treatment options. Here are some of the benefits, the pros and cons of each of these. Tell me about what you've had in the past. Tell me about what you're experiencing now. Tell me about your goals. Tell me about what you prefer. Can you get into can you go to a clinic? Does it need to be online? Does it need to be via phone? So nice thing about the VA is they offer a ton of different types of programs. A lot of them are even non-traditional, so like online yoga, stuff like that. So what the navigator would do then is talk with the veteran about, well, which one do you think might be most appropriate? And then they together make that decision. And then the navigator would help them get set up with that program or whatever that treatment would be in the VA. They'd follow up with them about 6 or 8 weeks later to see how they're doing. And then if they decided, yeah, things are going great, they could continue on with that treatment if they wanted to. But really the reason that was in there was because if they felt like, oh, I'm not getting where I need to get to, I'm not seeing the improvement that I need, or I've been waiting forever to get in and I need something else, they could help navigate them to something else. And then we had another final follow-up just to collect data essentially at 12 weeks out, so 3 months out. It's a 3-month program. We did see improvements over time, and their pain interference was the primary outcome in that trial. Physical function as well. We saw improvements in pain interference and physical function over time. I think one of the interesting things was we saw a lot of variation in what people used. And then we also saw a lot of change in what people use. At that 6-week time point, we also saw a lot of change. So people that, like for instance, were using acupuncture may have decided, oh, I want to use physical therapy, or I want to use acupuncture and physical therapy. It was more than anything a proof of concept that you can have a navigator program like that, and it can get you into these non-pharmacologic treatments pretty effectively. You can see some benefit from that. A few limitations, we purposely didn't control for or track outcomes of specific treatments. It would have been really difficult to do that with this model. So we don't know if people got better because they were in PT versus acupuncture. But really the goal was to understand whether or not people would actually use it and whether people would get better over time. We are doing a sort of a version 2, a phase 2 of that trial now. We were just funded through PCORI to do this. It's sort of like an enhanced navigator program where we're actually going to incorporate a lot of CBT into it. So we're going to do some, pain science education. We're going to do a lot of self-management training. So it's rather than just the navigation piece, it's actually going to incorporate a lot of education and almost like coaching into it as well.
Who are the navigators, Trevor?
The Navigator, so as a pragmatic trial, I don't know if y'all are familiar with pragmatic trials, we had to stay very pragmatic in that not every site was able to dedicate the same person or provider type to be a navigator. So we actually left it open. It could be anybody at their site. It was anybody at their site. Most of them were healthcare providers, So we had some PTs that were navigators. We had some nurses. We had we're called whole health coaches, which is a kind of a unique group in the VA that are kind of these holistic care providers. I'm trying to think who else we had. I think we had a few chiropractors that were our navigators, an OT, I believe, as well. So it was a lot of different disciplines.
Yeah, but they had a shared responsibility, right? So
They did, and we trained them all. Yeah, they all had standard training that we provided them on the navigation piece. So it's kind of interesting, maybe not surprising, is that for the PTs, we tend to see they sent people to PT a lot. For chiro, it was chiropractic care. So that was kind of an interesting finding as well, is that you can't completely lose that by. We tried to tell them, hey, just because you're a PT, don't send them all to PT. But it is difficult, I think, to lose that bias, when you're making recommendations on what might be most appropriate.
How do you see this program playing out in a more of a commercial space? Or do you even think that something like this is viable in a commercial space?
In the Navigator? Yeah, I think it could be. I mean, I think it's one of the challenges with this, obviously, is, how does this get paid for? Who pays for the Navigator? When the trial was done, we found, I think, only one of the sites continued on with it. And it's largely because, you need to dedicate time to have these calls and to do this. And so I think maybe even as full circle, coming back to what we were talking about earlier, is that, when you talk about at scale, doing something like this and potentially the money that you save by getting people in earlier to non-pharmacologic treatments, ideally that would reduce some of the longer term downstream use of really expensive treatments. And I think if you could sell that some of those cost savings could be used to support a Navigator, it's really difficult to make that sell. But, that could potentially be how it would play out in that space. But yeah, I think that's going to be one of the biggest barriers moving it and, into a more commercial health system space outside the VA,
I can
where
just touch.
you're not in a capitated, or environment.
Well, that's I built a Navigator program, very different population, but built a Navigator program in a health system for patients who had an acute event that we were managing there, either total cost of care or long episode of care. And the Navigator's role was integral. The reason that our organization was so successful in those models was because of that more high touch, transitioning through the health system, very variable experiences, very different levels of accountability depending on the site of care, and no one really owning the patient. So in that case, as long as you can make the ROI, that investment in the Navigator is a fraction of the dollars of total cost of care that you're going to save. It's, again, depends on the population. And a complex patient population where the risk of readmission or long lengths of stay, let's say in a SNF, or poor outcomes, or cycling the system, or ending up back in ICU, a lot of that is avoidable if patients have the ideal care journey. Easy to make that argument. But it's never going to be paid for just out of goodness of people's hearts. So we're just going to pay a Navigator. It has to come from taking that money elsewhere, and hopefully exponentially better. It's all about behavior. It's patients' actions are determined by what incentivizes them. By you activating that patient, it probably has less to do with where they end up going and more about doing something so they feel empowered and not on their own to go book something and expend on something that's not necessary.
I hear patient activation. I think of Jason Bourne being activated.
It's a big buzzword.
But Trevor, too, if you had just one final way of drawing people to your research, anyone who's going to listen to this, what would be the greatest lesson to learn from your research, and where can they follow you and track you so that they can continue to learn from you?
Yeah, I think the biggest thing that I've learned, and maybe it's something that others can learn as well, is just how important the whole person is. I think is, if I could sum up a lot of the work that I have either done intentionally or kind of fumbled my way into, is that it's really about the entire person. And I think the more that we can do to try to understand that and try to address a lot of those needs and listen to what those needs are and structure our treatment around that, the better off we are going to be in arguing that we provide value. And I think we probably need to come to terms with the fact that sometimes that may only be one visit, and that may only be a little bit of advice. And sometimes that may be a lot of visits, and, providing care that maybe we're not used to providing, but that is going to be really important for helping that patient get better, because that's where we provide that value. I really do feel like we have the capacity to provide a level of care that nobody else in the healthcare system does, but we've got to be willing to do that. And I think, unfortunately, right now, a lot of the payment models that we have just doesn't allow us to do that. It's we're being, hamstrung by those models. But I think that, we're starting to see that change. Just, consider the whole person, whether it be their level of psychological distress, their social needs, their, things that maybe you need to talk with them a little bit more about. And those are the things that are really important to them. In terms of following me, I don't do a ton on social media these days for a variety of reasons, but LinkedIn, I'm on. I try to post stuff on there here and there, Alex. I think that's where we connected. And then, certainly just I try to push out stuff through some of the Duke channels as well.
Such a pleasure to have you, and really
Yeah,
appreciate your time.
thank you so much. I really appreciate it.
Thank you for everything you
Sure.
do.
Absolutely.